Hello, and welcome to episode 73 of the Untethered podcast. This is your host, Hallie, and I am excited to get back into chatting about myotots and airway. So let's do it.
Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie Bulkin. I'm a certified orofacial myologist, feeding specialist, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started.
I want to bring you a topic today that has come up quite a bit. We were launching the Myo membership this past week, and we had a lot of questions about it. So I thought this would be great to chat about on the podcast. One, I will tell you that I actually teach on this exact topic in Feed the Peds, but let's take a little dive into orofacial myofunctional disorders in the birth to 3 population. So we specifically had questions from therapists who work in EI and early intervention, if you're not familiar with EI as a terminology. And they were wondering if our Myo membership would be appropriate for them because they work with the younger kiddos, and Myo is traditionally, a traditional Myo program is for 4 years on up. But here's the problem, right? Babies are born with orofacial myofunctional disorders. No one's really teaching that in introductory myofunctional therapy courses. This is why I actually specifically added both a Myo module and a TOTS module to our Feed the Peds course. Even though it's a feeding course, I think it's extremely important that everybody know that Myo is there at birth. And these children who need therapy at 4, things just tend to progressively worsen over time, but they were there since the baby was born. In fact, many times it was there in utero, most of the time, I should say. Let's give an example, right? If you have a baby who's born with a tongue tie, well, what we do know is that apoptosis or cell death, which you've heard me talk about on the podcast plenty before, basically failed to happen. And now the tissue under the tongue, or that frenulum, is tight, right? Now we've got a baby who's born. We start to have symptoms. We're going to talk about what these symptoms are in a second. And what happened? Well, what happened was this apoptosis failed to happen. And this can happen down the midline in general. So if the tongue is tight, we should also be looking at other midline structures, just as a side note. However, they start swallowing, they being the baby, infants, right? Or the fetus, whatever you want to call it, start swallowing at 12 weeks in utero, right? So baby's still in mom's belly, your belly, mom's belly. And, I say your belly because I know we've got mamas who listen to this. And baby starts swallowing at 12 weeks in utero. Now, what happens if you start swallowing and you're already compensating to do that even in utero? Well, now we have this pattern that is basically innate for this child, and it's not going to serve them well once they are out in the real world, right? So these babies are born with it. And I take issue with saying, well, we can't do a traditional Myo program with them until they're 4, as if we should wait, right? Because that is a lot. No one's actually saying, oh, wait till they're 4. I'm not hearing that so much. I'm just hearing this default answer of, oh, we don't do Myo till they're 4. I disagree. We can do and I've talked about this with Michelle Emanuel, who's been on several podcast episodes on here. So you can go back and listen to her conversations, our conversations that we had. But my message to you today is, if you walk away with nothing else, do not delay therapy until 4 years. That said, therapy looks very different for a newborn or an infant or a toddler than it does for the 4+ crowd. So that's what I want to touch on today. I want to talk about the signs and symptoms of orofacial myofunctional disorders in birth to 3. I want to talk about who's at risk of really developing bigger issues. And how do we stop that orofacial myofunctional disorder in this age group, right? So we're going to take a little dive down into that in today's episode. So what I will tell you is, if you're sitting here and you're like, well, who do I refer to? What kind of therapy is needed? Like, what do I do for this child? I want to help them, but I don't know how. What I want you to do is, if you're not trained in this yet, and if what I go over today in this episode is not something that you already do, please, please, please refer that infant. They are small, fragile infants. We can do a lot of harm if we don't know what we're doing. Please refer them to an SLP, a speech language pathologist, or an OT, occupational therapist, who can do feeding therapy, who specializes in doing like infant feeding therapy. That's very different than toddler on up types of feeding therapy, and who has a background in orofacial myology and TOTS, right, tethered oral tissues, so that they can integrate what they know there into their feeding program. Because this child is probably coming to you. What is the number one sign or symptom that I get when a parent calls our office to have a child, be assessed? It's feeding. Feeding is the big issue, right? They're having difficulty with nursing or bottle feeding is usually the first sign. Poor latch on bottle or breast. The suck, swallow, breathe is discoordinated. The tongue is unable to cup around either the breast nipple or the bottle nipple and draw milk in. There's impaired tongue range of motion. The tongue usually tends to rest maybe a bit too far forward. During feedings, we'll see it like come past the lower lip, or we might also just see the tongue rest between the lower lip, the upper and lower lip, or even just if the mouth is open, their mouth breathing, we might see that tongue resting kind of forward and even off the lower lip a little bit. Just is too far forward is the bottom line. We might see them sucking their tongue. We might see lip blisters develop because of misuse of their tongue and different compensations they're trying to make to feed. Oftentimes these kiddos, some other signs and symptoms now, so that's initially like the difficulty that we'll see with nursing and bottle feeding is the earlier signs, but then we move on to solids at some point, right? And we see a lot of, first we'll see these kiddos have trouble with transitioning from breast to bottle, right? Say mom needs to go back to work at 3 months or 5 months or whenever, and baby is making do with breast, but oh my gosh, baby refuses to take a bottle or just can't do it. And this is obviously a very stressful situation, but this is oftentimes when some of these kiddos land in our practice, and 3 months, 4 months or so, and mom is desperate to get baby to feed from a bottle because baby's going to daycare or with a nanny all day, and mom's going back to work, and she can't fathom her child not eating all day, but that appears to be what might be going on because this child refuses to take nutrition from something other than the breast. That can be a sign. We also tend to see open mouth postures at rest, right? We also might see a high nasolabial angle. They might have a diagnosis of failure to thrive. They may have GERD, which is basically reflux, but gastrointestinal issues can be very common too. More so, we might see that more so when they're actually on solids, as far as like constipation might come into play, versus like some gastro issues where they might be quote unquote colicky, right? When they're still just on liquid feeds in those earlier months of life, before any solids are introduced, and then, as I mentioned, once the food is introduced, we tend to see feeding challenges. So sometimes these are our kids who are described as picky or behavioral. Oftentimes I'll call them selective if they're getting to a certain age where like they're on a self-limiting diet, they're only eating a handful of foods. That can be problematic. They might have trouble transitioning to solids in general. And then sometimes we also see in more heightened and more severe cases, gagging and vomiting. Like the gagging is normal-ish when they're learning to eat a new food, but it shouldn't continue, right? If they're vomiting, that's not a good sign, especially if that's happening regularly. Some other signs and symptoms. So we might see some issues with speech development. So there could be impaired sounds or maybe just delayed expressive sounds. So delayed speech productions, we're not hearing them use these sounds, and if they're using them, then their intelligibility may be impaired. There's a good chunk of sounds that we typically will see. Now, obviously, a lot of these kiddos don't have those sounds early on, but that doesn't, and I'm talking about like in a more traditional myo sense, but that doesn't mean that other sounds might not be impaired, right? So we really need to look at like, what sounds are we having trouble understanding still? What should they have that they don't have? Are they making compensations to produce this sound? We really want to be looking at all of that. And then I prefer to get the pacifier out of the mouth around 4 to 6 months of age. So I typically will say that we don't really want to see a ton of non-nutritive sucking behaviors, like oral habits kind of developing. They develop around 6 months or so. So I look at the 6 to 12 month window, and I consider that a time to work on breaking some habits if we can. But definitely by 12 months of age, we should not be seeing any of those like mouthing of objects anymore, or non-nutritive types of sucking, right? And then excessive drooling. That's another big sign or symptom of an OMD if they can't control the drool. All right, so who's at risk, right? Who's at risk for all of these things I just described? Well, newborns who are born with an open mouth at birth. The baby pops out and that mouth is hinged open. Oh, you better believe we got some work to do, and we can help this child. That's the beautiful thing. And we should be doing this from day one, right? To make all of our lives a little bit easier, because this child might actually be able to change their patterns since they're still so tiny and moldable, and lead to better feedings, better speech production, our speech sound production, I should say, more intelligibility, right? And better, they say better sleep already, better feeding, all the things we've talked about. So who else is at risk? Well, any child, any infant or toddler we hear that has audible breathing. So it's not just snoring also, but it's not just snoring. If we can hear them breathing, it's audible, that's a concern. You should not hear your child or a child breathe when they are sleeping, whether that's napping or nighttime sleeping. Our pediatric feeding patients, holy cow, they're at major risk for this. And that really includes even the littlest ones who are still drinking from the breast or bottle, and especially those who have trouble transitioning to solids, right? So we need to look at that. We also need to look at TOTS and midline defects, as I alluded to before, because those children are also at risk. Preemies, we have to consider things like intubation, if they were premature, how long they might, like, were they in the NICU or not, how long. Really, we need to be looking at all of these things, because this can impact the airway, which can impact, other development. And we want to be looking at airway issues as a whole. We want to look at how baby breathes, how, like we talked about before, the suck, swallow, breathe. Is that discordant? Is that not coordinated? Because if that's not coordinated, that's a sure thing that we need to address, right? Are there sleep issues? Babies this young, though, should not be sleeping through the night. And it kind of drives me up a wall when we have sleep specialists, or I don't know what they call themselves formally, and I'm not hating on this as a profession. I am just simply stating that it's very dangerous to try to make your baby sleep longer if their body is waking them up for some reason. That reason, it may not be hunger, and breastfeeding moms should never be forced to think they need to sleep train their child versus on-demand feeding. I know there are sleep specialists out there who believe what I believe and who are educated in this. I'm not talking about you guys, but I see quite a few, especially in my area, who are constantly telling parents in Facebook groups that, well, your child is 6 months old, they should be sleeping through the night by now. And I'm over here going, is that baby breastfeeding still? Because that is some dangerous advice, especially if that mama thinks that that's what's normal, that they should be sleeping 6 hours through the night, and that baby still is waking up every, I don't know, maybe waking up once in the middle of the night to feed, and they're being told, no, they shouldn't, at 4 months of age, at 5 months of age, at 6 months of age, So make sure you do your due diligence, but also if your child is waking up that frequently, let's look at their sleep as a whole, but more connected to airway, because if your baby's waking up, something is up, and we need to rule out airway issues. It's not a matter of training them to sleep. Babies will sleep until they need to wake up for whatever reason. Okay, enough about that. But that's a very big, that's a pet peeve of mine, if you will. All right, so digestive issues, that's another one. Medically complex infants, right? And we're talking again about who's at risk for orofacial myofunctional disorders. Children who are hyper or hypotonic, so they've got either their tone in their body's too high or it's too low. They've got, high tone, low tone, head shape issues, rounded or protruded mandible, that's your lower jaw, torticollis, these kids oftentimes don't tolerate tummy time well. Children who are using compensatory strategies already to support their oral motor skills. And right now that could be for breathing and eating, and not oral motor for breathing necessarily, but definitely for, eating, if they are, and speech, if they are already compensating, like, woof, your antenna should be going up. If they have delayed speech or language, they're at risk. If they have delayed gross motor skills, they're at risk. If they are excessive droolers and you're switching out the bibs all day long, or they're oral sensory seekers and they're constantly putting things in their mouth, they are also at risk. Okay, so this is quite a list of kiddos that we really need to be taking a nice look at when it comes to orofacial myofunctional disorders, and see if they have any of this going on, if they're on that list of who's at risk that I just mentioned. Now, how do we stop the OMD? Okay, that OMD being the orofacial myofunctional disorder? Well, assess, treat, monitor, right? So let's break that down. We can assess oral rest posture. We want to see that tongue up and the mouth closed. Yes, that should be the case as soon as they pop out. As soon as they come out of the womb, they should have a tongue resting in their palate, mouth closed, nasal breathing. Okay. And obviously we want to assess for the oral rest posture. We want to assess for nasal breathing. We want to assess for TOTS. And it drives me up a wall because in places like Brazil, they have a tongue tie screening at birth. So you guys know, I know everybody, if you've had children here, and maybe if you haven't, but you're an SLP or in, the speech pathology profession, you know about universal newborn hearing screenings, right? Baby is born, every baby gets a hearing screening before they leave the hospital. And let me tell you, with one of my kids, they had to come back and they had to come back again. And then they had to wheel her, and this was Lily, actually, Mrs. Tongue Tie. They had to wheel her down to the audiology. They had asked me if they could take her down to the audiology lab to actually do an ABR on her and test her hearing, because one of her ears was just not responding. She was totally fine, but that was an interesting experience, right? As an SLP, I'm going please, yes, do check her. I want to make sure nothing's going on. But also very interesting, that they do that as a newborn screening. Why are we not screening for tongue ties and lip ties and buccal ties at birth? It literally takes 10 seconds to put your finger in there, feel for something, lift the tongue up, pull the cheeks out, look under the lips, top and bottom, and really just make sure that we don't have any concerns. Not that we're going to diagnose every child who might appear to have a tight one. If they're feeding well, okay, great. But if they are having struggles feeding in the hospital and you've given mom some lactation support and she's still struggling, or still, telling a mom it's not going to hurt in 2 weeks, just give it some time, or you're new, you just got to get used to it, or what, that's not helpful, and it's false information. Okay. We should be doing these screens at the hospital, and we should be educating and empowering our mamas, but that's a topic for another episode. All right. So then that's assessing. Treating. Well, obviously we're going to want to figure out and treat the root cause of the symptoms that are impacting, successful feeds. What is getting in the way of us successfully feeding this baby, and in the way of this baby sleeping, in the way of, them growing and really experiencing the quality of life we would expect for a newborn, an infant, a toddler, right? We want to make sure, and that also goes for the parenting side of things too. Obviously toddlers are challenging. I have a 2.5-year-old, and Lily's 5. She's not so far removed from being a toddler. They can be challenging. They come into their own and they know they have a say in the world, right? But that's very different than what we're talking about here from a quality of life standpoint. if that child is vomiting and gets kicked out of a pool, okay, I heard this is in the Myo membership this week. There was a child who is no longer allowed to go to the public pool because he vomits too much. That is impacting this child's quality of life. If this child can't go into a lunchroom, which I know schools are mainly closed right now, but humor me here. If that toddler can't even enter, and although I will say some daycares are open, so I retract that partially. But if the child can't eat at school, or the child can't sit in the room and eat with other peers because it's of the sensory aspects of being in that space, or whatever, right? The quality, that is a quality of life change for this child. That is important to know. And that is also considered something that would be worth, treating, something that would be worth looking further into and figuring out, like, what is the root cause behind this? Why is this happening? So that we can treat it. Okay. And then monitor, right? We want to monitor facial growth. We want to monitor posture. And that's both, like we're looking at neck, back, shoulders, this, when I say the back, like look at the spine. Is it nice and up and down and straight, or do we feel like the child's starting to get a little torqued? And the neck, like, do they appear to have some unresolved torticollis? Do they have a side preference? Does their head tilt a little one way versus the other? Really looking into that type of posturing, as well as monitoring oral rest postures, and swallowing. What is that looking like? We want to monitor their developmental milestones, oral motor feeding, gross fine motor. Remember also, going back to postural control and posture, remember that it all is it's basically, like we always say, like what you see here is what you see there. And that has to do with the core and the mouth. Some people will say what you see on the hips is what you see on the lips. Basically just kind of demonstrating that our torso area is really the base for feeding. Like, we need some good support there in order to support feeding and everything that goes on above that grand station down there. So bottom line is, we need to be looking at posture. We need to remember the importance of postural control at the core, because it is tied to our mouth's ability to do its job and do it well, and fully supported. And we need to monitor sleep. We need to monitor saliva control, especially if there is drooling going on. And if the parent feels like, well, maybe it's happening because of teething, maybe, but that should end pretty quickly, right? So let's monitor that. And then dental eruption. That's another big one. Sometimes there's delayed dental eruption. Well, why is that happening? Is something going on with the bite? Is it tongue resting in the wrong place? Like, is there something that we can possibly help with that is in the way of more traditional dental eruption? We don't move teeth. We don't do dental types of things, but we can work with the tongue, right? And I'm talking about orofacial myologists and feeding therapists. We are not in the business of moving teeth. We are not dentists. And so, so just be careful how you approach that or discuss that, with a parent, but, or if you are a parent, FYI, but basically dental eruption can be impaired by the oral rest posture. Okay. So definitely something to look at. So what are my recommendations for you, right? Let's wrap this up. Well, breastfeeding is ideal if that is mom's desired form of feeding. If not, then you bottle feed, and you better help that mama figure out which bottle is going to work for her baby, right? But that also comes with an entire treatment plan and doing some oral motor work. Also doing lots of tummy time, right? We want them on their bellies. We want them learning how to use their head and their neck, hold their head up and gain better control. But if there's torticollis in place, this may be uncomfortable for them. And so that you might see some resistance. Okay. But again, that's a sign and symptom of an OMD, isn't it? So what can we do, right? So breastfeeding, as I mentioned, lots of tummy time, transition to a modified baby-led weaning approach. So if you're someone who has started with just using traditional baby-led weaning, which means there's like no spoon involved, there's no purees, basically not no spoon, but you're not feeding your child, I encourage you to transition to, and this is Jill Rabin's term, modified baby-led weaning. We actually talked about this on episode 31 of the Untethered podcast, so you can go listen to it. But children, they need a combination of puree and you spoon feeding them, while also allowing them to explore safe foods, textures, and presentations, right? Pacifier, right? You guys know, if you've followed me for any short period of time, you know what I think about some of the pasties out in the market. Either way, if you do use them, out by 4 to 6 months, 6 at the latest is ideal, because that's when habits form, and we don't want that to form into a habit. We want to provide appropriate oral tools for exploration based on their age, appropriate for their age and their development level. And then we want to introduce open cup and straw cups by 6 months of age, right? Weaning from the bottle if they're using a bottle by 12 months of age. So this last, list of recommendations I gave you are things that you can absolutely start putting into play now that will help benefit better orofacial myofunctional development, right? Because the goal is, if they're born with an OMD, an orofacial myofunctional disorder, whether it's a tongue tie or there's something else going on, one of these other signs or symptoms that we talked about, we can absolutely do passive therapy and start to work towards the overarching goals of myo with, mouth closed, tongue up, nasal breathe, eliminate any sucking or oral, I should say noxious oral habits. We should be eliminating those, so those are the kinds of things that we can be doing, but that should come from you as the therapist on the team, where you can say, hey, look, I'm assessing for oral rest posture, TOTS, nasal breathing right now. Okay, I found X, Y, and Z. We're gonna, I think that's being caused by this. So let's treat the root of the problem here. We're gonna work on this so that we can get back to successful feeds and successful sleep and successful growth and, a great quality of life for the infant and the parent or parents. And then we're going to continue to monitor these things, like I talked about, like facial growth and posture and developmental milestones, sleep, saliva control, dental eruption. We will monitor all these things, right? And so there's definitely things that we can be doing. And that's what I wanted to open up your eyes to today. I hope this is helpful. Go back, listen, take notes, but also I put this all nice bullet points, completely detailed for you in the show notes. So grab the show notes for this one if you want just a nice PDF of, what are signs and symptoms of OMDs in 0 to 3-year-old children? Who is at risk for an OMD? How do we stop the OMD? What does that assessment, treatment, and monitoring look like? And what are next recommendations? So if you want that, grab the show notes. This has been so much fun talking to you guys, because I love all things myo. And if we can stop it in its tracks in these little ones when they are newborns or early on in their infancy, holy moly, we will be looking at a very different future. So my goal is to work on these babies while they're still babies and they're so moldable, and give them the best possible opportunity at having a nice open airway and having, nice developed jaws and all their other skills that they're developing. So I could talk about this all day. I love this topic, but let's get out there. Let's help our babies. Let's not be waiting until they turn 4, right? And as you start to work with them and you keep in mind what your feeding goals are and you keep in mind what your myo goals are, you're going to start to realize how much they actually go hand in hand. And it's almost hard to tease out, well, is this a myo issue or might this be a feeding issue? Or, it really doesn't matter so long as they have a nice oral rest posture, they are swallowing properly, right? And they're not experiencing all these symptoms we've talked about today. So that's the ultimate goal. I hope this was helpful for you all. I'd love to hear some feedback on it and let me know. We've got some great guests lined up coming in our upcoming episodes, but let me know who else you want to hear from, what topics you want to hear more of. I love inviting individuals on the podcast that you all specifically request. So go ahead and, email us, let us know what you think, who you want on the podcast and what you think we should be talking about. We'd love to bring you more of what you all ask for. Those are always fun to record. Hope everybody has a wonderful rest of your day. We will chat soon.
Thanks for listening to this podcast. If you want to hear more of these myo, TOTS, airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Bulkin Biz, on Instagram at Hallie Bulkin, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.